Hello, everyone. This is Tom Glenski again, and we're up and running again to start our webinar. Thank you for joining our webinar today. Today, we're going to do a legislative update. Kim Grinston, our executive director, is here, and between the two of us, we'll give the program today. You're all in listen-only mode. If you have any trouble listening over the computer, you do have an option to choose to call in on the telephone number listed and listen over the phone if needed. We will be giving 1 hour of CE for today's program. You must be signed up and logged in on GoToWebinar in order to get the CE. At the end of the program, I will go over the CE instructions again. CE is not submitted to the CPE monitor, so please save your certificates. We'll mail them out to you later. We did post handouts on the board website today. We also emailed them to anyone who had signed up as of yesterday, so you should have got an email with the handouts. We do make a recording of all our webinars, and they can be found on our website. We'll try to, if time permitted, we'll try to take questions at the end. To submit a question, go to your GoToWebinar toolbar and just type in the question and hit send to send it to us. Today we're going to talk about the legislative session that just happened and the statutes that will be changed from that session, and then we'll also give a brief regulation update on some regulations that have been changed, and then as I said, we'll try to take questions at the end. So right now I'm going to turn it over to Kimberly Grinston, our executive director.
Thank you, Tom, and good afternoon, everyone. We have a lot of information to cover today. The 2018 legislative session was very busy. There were several pieces of legislation that relate to pharmacy that we want to make you aware of. So we apologize. We're going to be giving a lot of information. Also, we'll be providing some follow-up information if you have any questions. We hope to get through all of these by the end of the webinar today, but if not, the board will be sending out an August newsletter that we will be mailing to all licensees. So a lot of the information that we're going to share today will be provided in the newsletter as well. As Tom said, we will be taking questions during the webinar, so please feel free to ask your question as we go along, and we'll try to answer as many as we can. So let's begin by looking at the major changes this year in legislation. Just by categories, there were changes in the immunization age, Show Me Vax reporting, two-line prescription format, generic substitutions, consolidating medication, the opioid supply limits, buprenorphine prescribing, drug take-back programs, pharmacists continuing education, and then also some changes with third-party logistics and drug outsources that we'll just briefly discuss at the end of the meeting. Again, let's go ahead and jump into it because we've got a lot of information to provide today. So we'll start with changes to 338.010 and the immunization age. The immunization age, the age that you can vaccinate someone, has been lowered to 7 years old or to the CDC recommendation, whichever is higher. In the past, that was 12 years old. While the age has been lowered by statute, pharmacists, licensees should check their protocols to make sure the lower age is allowed in your protocol, because if your protocol has a different age requirement, you would have to comply with that. We are encouraging licensees to go back through their protocols for other reasons, because we changed the protocol rule, because there may be some other things that may need to be updated as well. Show Me Vax reporting. Section 338.010.13 was amended to now require licensees to report to all vaccines administered to Show Me Vax, and this is specific to pharmacists administering vaccines. Show Me Vax, for those of you who may not know, is Missouri statewide immunization registry. It's operated by the Department of Health and Senior Services. It's not operated by the board. Senate Bill 826, and I forgot to add that all of the legislation that we discussed today will be available on the board's website within the next week or so that you all can see the actual legislative language. But under Senate Bill 826, all vaccines must be reported to Show Me Vax unless the patient opts out of reporting. Again, that is all vaccines administered by a pharmacist or in intern pharmacists. ShowMeVax provides two reporting options. You can either upload vaccine data using a pharmacy technology system or a reporting service that is what DHSS calls HL7 compliant. It's a specific set of education and software standards. Or if you don't upload vaccine data, you can also report online using ShowMeVax's website. What's important to note is that you do not have to purchase a new system. If you're reporting online, you may not need to purchase new software at all. Your current software may already be HL7 compliant, or you may be able to contract with the reporting service. But even if you choose not to do that, you can now also report online via ShowMeVax's website. If you're using the website, it currently supports only Internet Explorer for Windows PC. It does not support any of the Mac Internet options, Safari, those kinds of things. But if you have IE, you can report online. There are two ShowMeVax reporting options. You can file either an inventory report or a historical report. An inventory report is basically uploading your vaccine data. You're not doing anything manual, it's automatic. A historical report, someone would physically have to go in and enter the vaccine manually into ShowMeVax's system. I should note that we are planning to hold a webinar with the Department of Health and Senior Services to provide some additional information on ShowMeVax and ShowMeVax reporting. Some of this may be new for some of the licensees on the webinar today. Others of you may be using it already, but we want to make sure we're giving that information so that you know what you need to do. To register with ShowMeVax to file a historical report, and again, that is the manual report, there are some registration requirements. You have to complete a memorandum of agreement with the Department of Health and Senior Services. You also have to register for their ASAP program. You'll see the full name on your screen. That is a program that allows you to access DHSS's system. And all users who will be reporting to ShowMeVax must complete an online training. It's online. The training is approximately 90 minutes. It can be taken on demand, but everyone who will be entering data into ShowMeVax must complete the online training. Now, I would note that that doesn't include all pharmacists. You do not have to go through the online training unless you will actually be reporting data as well. For the inventory reporting method, there is a different memorandum of agreement. Again, information on that would be available on DHSS's website. We'll provide that website in a moment. ShowMeVax reporting is mandatory unless the patient opts out of reporting. And if the patient does opt out, if the patient says they would not like to report to ShowMeVax or to have their information reported to ShowMeVax, written notification must be provided to the patient's primary care provider within 14 days. Again, that is only required if the patient opts out of ShowMeVax reporting. The board is in the process of providing additional information on this in the August newsletter. We hope to also have a sample notification form that pharmacies could use as well. The notification elements are those elements that are in 01013 right now. So it will be basically the same information that pharmacists are reporting right now, the same notification, except that, again, the patient has to be given the opportunity to opt out. Board is going to issue additional guidance in the August newsletter. There will also likely be a separate ShowMeVax webinar that we discussed previously. If you have questions about ShowMeVax reporting, DHSS's contact information is on your screen. We also going to have a link on the board's website to DHSS's system and the ShowMeVax informational website page so that pharmacists can also look on the board's website and go to ShowMeVax. I think that reporting to ShowMeVax may be different for those pharmacies who are not reporting now. The board will be voting on some additional guidance on ShowMeVax reporting next week during its meeting in Springfield, Missouri. If we have anyone from Springfield or in that area on the call, please feel free to join us. Meeting information is on the board's website. We would like you to direct ShowMeVax questions to the Department of Health. The board cannot answer ShowMeVax questions simply because we just don't know the answer. So I want to send you to the best resource. Other major change. Section 338.056 was changed to eliminate the two-line prescription format. So the current requirement that there be 2 lines on opposite ends of a prescription is no longer required in Missouri. You can still fill a 2-line prescription if one is presented. You're just no longer required to have one. Out-of-state prescriptions have to comply with the law of the applicable state. So the question then comes up, what happens with generic substitution if you do not have the signature line there anymore? Generic substitution is allowed unless pharmacists can exercise their professional discretion and substitute a generic unless the patient specifically requests a brand name or a biological product. 2, the prescriber indicates substitution is prohibited in some manner. And again, this is much more flexible than the current signature line. They may write DAW, brand medically necessary, or any similar language that reflects that they don't want the prescription to be substituted. I have to add for generic substitution, under the statute it says that the substitution must be less expensive. And so I would note that for those who are going to be substituting in the future, this really empowers pharmacists. So instead of getting prescriber approval up front, pharmacists will automatically have authority to substitute unless the prescriber says otherwise. Pharmacists cannot substitute with a drug that has been rated by the FDA as inequivalent or a biological that has not been rated by the FDA as interchangeable unless you get prescriber approval. And that is the law right now. A few other changes: consolidating medication. Section 338-202 currently provides that pharmacists can consolidate refills for up to a 90-day supply. However, the 90-day limit now does not apply to prescription dispensed to a member of the U.S. Armed Forces if they are serving outside of the United States, or if the prescriber is located in another state. And again, the prescription must comply with the law of the applicable state. So just a small change on in 202 on supply limits for consolidating refills. Probably one of the major changes would be the changes to opioid supply limits. So effective August 28th, 2018, and I think I forgot to add that previously on the call, all new legislation will be effective on August 28th, 2018, except for the take back language, which is currently effective. I'll talk about that in a moment. But Chapter 195 was amended to require that all initial prescriptions for an opioid for acute pain must be limited to a 7-day supply unless some other exemption applies. And we'll talk about those exemptions in just a moment. So what is an initial prescription? An initial prescription is a prescription for an opioid that was issued to a patient who has never been issued a prescription for the drug or its equivalent, 1, or 2, a patient who has not used or been prescribed or administered the same medication within the last 5 months. And so I think legislatively the goal here was to target, as Missouri and the entire nation continues to address the opioid crisis. I think one of the goals may have been to target those patients and limit supplies for patients who may be opioid naive, either because they've never been on the medication before or because they haven't used it in the last 5 months. I would encourage everyone, and again, this will be posted on the board's website, to go back and read this language because it's not the best legislative language, but it does have some very clear guidelines. The 7-day limit applies to prescriptions for acute pain, and you will see on your screen a definition of acute pain. Generally, it's pain for a short period of time. And again, there are exemptions to what is not considered acute pain, and you will see that at the bottom of the screen in red. For better discussion, though, the exemptions generally are patients undergoing cancer treatment, patients receiving palliative care, patients receiving hospice care, residents of a long-term care facility, patients being treated for substance abuse or opioid dependence, and prescribers, or if the prescriber deems a higher supply is medically necessary. And I want to stress that last exemption. So you have patients who are in special care treatment sessions and or have other treatment needs, but you can always exceed the 7-day supply if the prescriber determines that a higher supply is medically necessary. The prescriber is required by law to document why they believe a higher supply is needed and why another opioid will not be as effective, but a prescriber can opt out and prescribe a higher, more than a 7-day supply if deemed medically necessary. I'm going to walk through a few examples, and we've actually reviewed these with BNDD. BNDD is going to be providing some more information on this as well. So our first example, you have a patient who has a tramadol prescription. It's been issued for acute pain. She indicates that she hasn't used or been prescribed anything in over a year. Absent additional information, the prescription would be considered an initial prescription, and the 7-day supply limit would apply. Again, the patient has not been issued or administered or taken the medication within the last 5 months. Another example, patient presents a hydrocodone prescription for a 30-day supply. The patient is asked, and she said she had a tramadol prescription filled at another pharmacy a few months ago in July. And the prescription was issued for acute pain. Again, that is key, issued for acute pain. Absent additional information, this prescription would be considered an initial prescription. Again, while they've had a prescription for tramadol, they have not had a prescription for hydrocodone. So when that opioid changes, the 7-day supply limit may kick in. And I want to note that this goes either way, therapy is adjusted. So if you go from hydrocodone to tramadol or tramadol to hydrocodone, the 7-day supply limit would apply if the patient has not used, been administered, or prescribed the medication within the previous 5 months. Another example, you have a patient with an oxycodone prescription for a 30-day supply. The patient is undergoing treatment for colon cancer. This is one of the exemptions under the statute. And statute specifically, it says the 7-day supply limit does not apply to patients undergoing cancer treatment. That would include patients undergoing hospice care or palliative care as well, and residents of a long-term care facility. Another example, patient presents a prescription for a 30-day supply of Norco. The patient normally gets a prescription for Norco filled at the pharmacy or at another pharmacy. This time the prescription is for Lortab. Since the patient has been using the medication within the last 5 months and prescribed the medication, it would not be considered an initial prescription, even though brands have changed, and it would not be subject to the 7-day supply limit. Finally, another example, a patient is prescribed hydrocodone to treat chronic pain from a back injury. Absent additional information, again, the 7-day supply limit would not apply because the patient is being treated for chronic pain. I know we walked through a lot of that information rather quickly, but again, this information will be on the board's website. We will be mailing out the August newsletter, and we'll take questions in just a moment. So we've gotten this question already in the board office. How will a pharmacist know if a prescription is an initial prescription or for acute pain? The board recognizes that, in many cases, you may not have access to all of the documents to really assess this. And we also recognize that you are not the prescriber that's actually treating the patient. However, pharmacists are reminded of their corresponding responsibility to make sure that a prescription is valid and complies with applicable law. The board is recommending that pharmacists exercise good faith, take good faith efforts to make sure a prescription is not subject to the 7-day supply limit or has been appropriately prescribed. That may include a variety of things: asking the customer, contacting the prescriber, actually looking at your records. A lot of you may have the patient's dispensing records at your pharmacy, and you may already know if the patient is being treated for acute or chronic pain, or if the patient has been prescribed the same opioid within the last 5 months. Document your efforts. I think that both BNDD and the board will be doing a lot of education as the 7-day supply limit is rolled out. We would recommend that you document what you do to verify that something is or is not an initial prescription if it seems questionable. Let's talk about drug take-back. You all may know that a few years ago, maybe 2 years ago now, the board amended its rule to authorize drug take-back programs subject to state and federal law. Federal law, of course, already authorized it, but we had some language in state law that said that limited take-back programs by pharmacies. This year, that language was corrected, so state pharmacies can now take that medication in compliance with state and federal law. You will have to amend your BNDD and DEA registrations to be a collector. BNDD has information posted on that on their website. Check with Mike Boger and BNDD, I think yesterday. BNDD plans on doing an emergency rule. They are advising that they will not be amending registrations until the emergency rule is placed. I understand they intend for that to happen very quickly. Buprenorphine, the statute was amended to allow APRNs, physician assistants, and assistant physicians, that's still a tongue twister. They can now prescribe up to a 30-day supply of buprenorphine for patients receiving medication-assisted treatment for a substance use disorder. They still have to have a collaborative practice, a supervisory agreement with their applicable, with a physician. Physicians can always restrict this authorization in the governing practice agreement or protocol. If they are authorized to prescribe buprenorphine, they must have an ex-DEA registration and also complete the required training. And finally, third-party logistic providers and drug outsourcers. Currently, these entities are licensed as drug distributors in the state of Missouri. Chapter 338 was amended to create a new 3PL and drug outsourcer license. The board will be reviewing rules next week to implement our 3PL and drug outsourcer licensing. If anyone is interested in that information, please continue to monitor the board's website. We also encourage you to sign up for e-alerts because the board will provide additional information on there as well. Pharmacist continuing education, the chapter 324 was amended. This is not the board's statutes chapter, but chapter 324 was amended to allow healthcare providers to complete suicide training, and it also provides that that training can now be accepted for CE. It does not have to be ACPE approved. We are going to be mailing out renewals for pharmacists on next week. So suicide training can be accepted as continuing education. However, prior board approval is required. So while it's eligible for CE, you still have to request board approval before you take the actual program. And again, before we leave statutes, once again, another reminder, this is a CE renewal year. All pharmacist licenses have to be renewed by October 31st. Your CE must be complete by the time you renew. Please do not wait until the last minute to renew. We want to make sure that we have everyone renewed by November 1st as we need to. So that's a very quick summary of the statutory changes. We'll be taking questions on that in just a moment. Tom is now going to give you updates on the regulatory changes.
Thanks, Kim. I'm going to just give you a brief update on some of the regulations that have changed or will be changing in the near future. The first one is the one in regards to electronic transmission of prescriptions. It became effective on June 30th. It's a revision, an update of the old rule that was called transmission of prescription data. We renamed it. That old rule was written in 1996 prior to any e-prescribing or anything. So we brought it up to date with current technology. And then we reworded the section on when security paper is required for when a doctor is applying a electronic signature to a piece of paper they're going to give to the patient. There's no real major changes in that rule. Just we brought it up to date and revised it a little bit. The next rule is administration by medical prescription order. This is not by protocol. I will talk about that in a couple slides. The changes on this one have to do when a pharmacist is administering by medical prescription order. It eliminates the need to have the statement pharmacist to administer on the prescription. So now any prescription you get, regardless, you have the ability to administer that drug if deemed necessary. There's going to be less data recording on your administration records for non-vaccines. For vaccines, the standard still applies, but for non-vaccines such as B12, Depo-Provera, anything other than a vaccine, there'll be less data that you have to record on your administration document. If you're allowing an intern to administer under your supervision, your records now have to identify the intern and who the supervising pharmacist was at that time. The new rule eliminates the CE requirement for this. However, you still have the CE requirement for by protocol, so you're still going to have to do CE if you're doing by both methods. It updates the section on CPR to say it must be a provider level CPR course or basic life support BLS. That will be going forward the next time you update your NOI, you'll have to have if you don't have a provider level CPR BLS, you'll have to be using that. It allows adding a route not covered in your initial training. Most pharmacists have had immunization training, so they were trained in IM and sub-Q routes. If you want to do a route other than those, it now has an option. After you had your initial training, you can take on a new route. It requires that you get training by a healthcare professional who does that route, and you document your training. So we've had requests from hospitals to allow pharmacists to be able to administer drugs, say during code or in the ER. This does not apply, our rules do not apply to what's occurring in the hospital. We've had some questions already come in about this. You're going to need to ask the Department of Health on what you need to do to allow your pharmacist to administer by those routes. It will allow vaccines to be given outside the manufacturer's recommendation. Vaccines have to be within CDC guidelines, but for non-vaccines, we removed the limitation that you have to stay within the manufacturer's recommendation. So if a drug has let's say, a minimum age of 12, and a doctor wants to go below that, you now can do that if the doctor prescribed that. It eliminates the prescriber notification requirement for non-vaccine. Again, for vaccines, everything stays the same. You still are required to do that. But for non-vaccines, you will no longer have to notify the prescriber you provided that administration. It will allow the NOI, now it will be a part of your biennial pharmacist renewal process, similar to those who have MTS certificates. The renewal will be done when you renew your pharmacist license. So going forward, anybody new to administration will have to go online and do the current NOI. And then after that, and for all those that are currently have an NOI, on your renewal this year, you'll have a chance to renew the NOI, and it'll be good for 2 years. And it removed the prohibition that you could not administer if you were on probation. That has been removed. If you're on probation, as long as your disciplinary order does not say you're prohibited from giving administrations, you're allowed to do that now. So we've had a lot of changes to the administration by medical prescription order regulation this year. Again, I will talk about by protocol in just a couple slides. Lower renewal fees. This is the slide everyone likes to hear. The board did, by regulation, lower the renewal fee for this year down from $200 to $100. And then previously, the technicians this year that renewed at $10 instead of the usual $35. And then pharmacies and drug distributors last fall renewed at a much lower rate of $150 instead of the usual $450. These reductions are all one time. The fees all go back up to the normal in parentheses unless the board, before the next renewal comes, changes them again. So right now, for this renewal period, it'll just be $100 for a pharmacist renewal. Okay, now I'm going to talk about the protocol rule. It's in process. It is set to go into effect on September 30th. So the changes I talk about right now are not currently in effect. But the first change will eliminate the 50-mile requirement that the physician be within 50 miles of the pharmacist. So what this means is, especially for people with multiple locations that are more than 50 miles apart, you can have one physician in the state cover all your pharmacies in the state. It will allow electronic signatures on protocols. We currently already allow that. The regulations now actually specifically says that. So instead of having pharmacists physically sign a piece of paper, they can do it online and do an electronic signature. It will now allow the protocol to dictate whether you have to notify the protocol physician of notifications. Currently, you have to do it for every vaccine given. You have to tell your protocol physician, notify them that you gave it. This will allow you and the physician to work out among yourself if they want those or not. If they don't want them, then the protocol just needs to say that you will not be providing protocol physician notifications. If they still want them, then you'd leave that in and follow what your protocol says. This is only the protocol physician. Any PCP notifications or adverse reaction notifications are still in effect. And then the last four are very similar to the changes made to by medical prescription order. Interns need to be identified in your records, who they were if they're administering and who the supervising pharmacy was. Your NOI will combine, you'll have two of them that will be done at renewal, like I mentioned. And then the CPR change will be the same as in administration by medical prescription order rule, and same with the probation, not automatically prohibiting you from doing it. So again, this is effective September 30th. It will be published, the actual final version will be published, I believe, in a Code of Regulations on 9/1, and we'll post that once we have a copy of that. Another one that's in process is going to be an emergency rule dealing with the sterile compounding rule. It will revise two things. It will revise the remedial investigation section of the rule, and it will change when you have to actually shut down compounding activities based on remedial investigation. So, and then the other thing is a clarification on if in-use times applies to nuclear, and it has changed the time frame that it would apply for nuclear. Like I said, it's an emergency rule. It has not been filed yet, so we do not have a date yet, but again, watch email alerts. We'll let you know as soon as that rule has been filed. Since it's an emergency rule, it will go into effect within 7 days, 10 days of being filed. So we hope to have it shortly. Okay, that's it for the regulation update. We're now going to take some questions that came in.
While Tom is reviewing questions, I would note for everyone on the call that the board has really been working on slimming down some of their rules. You'll notice, especially with the admin by prescription order and the vaccine by protocol rule, that the board removed a lot of the paperwork requirements to possibly make immunizations and administrations easier for pharmacists. A lot of the unnecessary requirements have been taken out. So you will see those when you see the full immunization by protocol rule published. I think there are a lot of things in there that can benefit licensees.
Okay, we'll take some questions now. If you want to submit a question, go to your toolbar and just type it in and hit send. You can send more than one question, as some of you know.
Sure.
So the first one is, do I still need to post my NOI notification?
And the answer to that question is yes, you still do, and you can print those off on the website. If you go through the board's website and do a pharmacy search and then enter your name, it will tell you when your NOI was filed. Again, it will also tell you your NOI expiration date, effective this renewal period. We will be changing that expiration date to coincide with your pharmacist renewal. So everyone who renews their NOI at the time, while you renew this year, your NOI will expire in 2020.
Okay, we've had a lot of questions in the office about this. Someone's asking, in order to give vaccines, do I need to take a new certificate program? They're referencing that the new rule includes that a certificate program must include emergency procedures.
The answer to that question is no. Your current certificate program is fine. If you have a current NOI and you've already qualified, you will just be renewing. Those requirements will apply to those who are asking or filing a new NOI for the first time they're coming in new. So you don't need to do additional training. That's the same thing with your CPR requirement right now. Now in 2 years for your CPR renewal, you will need a healthcare provider level CPR certification or BLS certification. But no, you do not need to take a new certificate program.
And we've had other questions about, well, what certificate programs do meet? Most of pharmacists took the APHA, I think it's called pharmacy-based immunization or something. Their program, it does cover how to handle emergencies such as adverse reactions, and almost all the programs, the school programs that have been submitted to us to review include some of that. So I really don't think there's any programs out there that do not cover how to handle an adverse reaction. Okay, questions about ShoMeVax. Do we still need to notify the PCP if entered into ShoMeVax?
And the answer, the board will be doing some additional guidance on this next week and in the August newsletter. So I'd encourage you to wait for that. But right now, it is the board's last intention, or they indicated that notifying ShoMeVax would meet the PCP notification requirement unless your protocol possibly says something different.
Okay, are we supposed to ask the patient about ShoMeVax? And specifically, are they supposed to be asking, do you want to opt out?
The statute reads that you have to notify the patient that their information will be entered into ShoMeVax, and the patient has to, quote unquote, attest to entering the information and be given an opportunity to opt out. We believe that this can be done on a form. Again, next week, once approved by the board, we'll do or have a sample notification form or something that just generally says that tells the patient your information will be reported into ShoMeVax by signing below, I agree to ShoMeVax reporting unless I check the box. So it can be something that very general. We hope that this will not be something burdensome. And I do need to note that this was not a piece of board legislation that we're talking about, but we think that you can use a simple form and do it all in one process. And that could be either manual form, an electronic form, or verbally, but you do need to document that the patient attested to reporting to ShoMeVax.
And then a follow-up to that question is, if they do ShoMeVax, are they required to still notify their protocol physician? And the answer would be currently yes. When the new rule goes into effect on September 30th, then your protocol will dictate that. So on September 30th, if you want to amend your protocol with your physician and stop doing them, you would do an amendment or a new protocol, and then you would not have to do that, period, regardless of how you notified the PCP. Is the lower immunization age currently in effect?
No, not yet. That will go into effect August 28th, so you have a few weeks yet. But again, check your protocol, because if your protocol still says 12 or older, whatever the age may be, you do not have authorization unless you amend the protocol. And to amend the protocol, both the physician and the pharmacist, that would be a substantive change, would have to sign.
I'm just trying to get more ShoMeVax questions now. But
someone asked about the 50-mile rule for immunization by protocol. Effective September 30th, 2018, the 50-mile rule will be gone. So you have a few more weeks yet, but then after that, again, you will not have a mileage restriction for protocol physicians.
Does ShoMeVax only apply to Missouri residents?
The way the statute is written right now, it says any vaccine administered by a licensee. So I think if a Kansas resident or an Illinois resident or someone from Florida is in the state of Missouri, if you immunize, you should be reporting to ShoMeVax unless the patient opts out. And if the patient opts out, you're required to give PCP notification in writing.
Okay, if a pharmacy chain is currently pursuing HL7 setup with a vendor for automatic reporting, what is expected for submitting data until the automatic setup is completed?
The board is actually going to be issuing guidance on this, and so I can't give you anything binding right now, but the board initially suggested that for pharmacies or licensees that are actively engaged in registering with ShoMeVax, the board will allow you to continue reporting under the current rules, meaning written notification to the PCP when required, while you're working through and getting your system up and online. I would note that DHSS has indicated that they are expediting pharmacist requests to register with the system, and it may take some time for registration to occur. But yes, you will have a little bit of a phase-in time. The board will be issuing additional guidance on that in just a moment.
Okay, so someone's trying to do an NOI search on themselves and saying they're not showing their NOI. So when you go, there's multiple searches on the division's website. So if you go to our website, the Board of Pharmacies, and on the top banner it says licensee search, and then you get a bunch of choices. You have to go down and pick the one that says pharmacy licensee search. You can't do the division licensee search. It will not show you NOI information. You have to come down and choose the pharmacy licensee search. So if the person who is having trouble, if you do that and you still don't show up, please contact the board office and they can tell you your NOI status there. Okay, now we got a bunch of questions on opioid prescribing. Have urgent care emergency rooms and all doctors been notified of this change?
I don't know. I hope so. I know that BNDD is going to put out some information. The Board of Pharmacy will, once the August newsletter is approved. We have talked with the Board of Healing Arts, and I don't know what type of educational campaign they will be doing for their licensees, but I anticipate that they will be notifying them as well.
Okay. Is there any required documentation needed if a physician states it is necessary for a patient to receive greater than a 7-day supply?
Well, the statute says that the physician has to document in their records that greater than a 7-day supply is required. While it doesn't address pharmacists, we would suggest that pharmacists document, especially if it's, you talk to the prescriber and they tell you why it's more than a 7-day supply. Document that in your records so that you can show proof of compliance.
Multiple people have asked, if you get an initial prescription greater than the 7-day supply, does that void out the remaining? So they wrote a 30-day supply. You find out that the patient only qualifies for 7. We will double check, but because the statute is written, this is written for a prescriber, that they cannot prescribe for more than that. I believe it voids it out, but we will double check with Department of Health and BNDD, and that will probably be in our newsletter coming out. But my interpretation would be, because that's written for the prescriber, that that prescription, the remainder probably would not be. But we'll double check on that. It says if you do have to lower the dose, the amount quantity, do you have to notify the prescriber? I believe for C2's DEA requirement would require you to do that. I do not believe so for 3 through 5, but under C2, DEA C2 regulations, if you don't dispense the full amount, I believe you have to notify the prescriber. That would be probably something else we should address in the newsletter.
We'll actually take these questions back to BNDD. As we implement the statute, I think as with any new law, there will be a period of education. And so if you have any additional questions after the webinar, please submit them to us, because we want to make sure that we're getting you the answers you need. Someone has asked, if a hospital enters into Show Me Vax, does the pharmacist need to enter also? As long as the pharmacist ensures that that information is in Show Me Vax. You can delegate that to the hospital. You can use the hospital system, but it needs to be in Show Me Vax, or you need to have something from the patient opting out with written notification to the PCP.
We have an intern who's scheduled to take the MPGAE who wants to know, will these new rules be included? We've actually pulled any questions related to those, so you shouldn't see any questions on these new changes.
So for all the students on the webinar, don't worry. Questions on the new law have been removed. There's a question on what level of CPR is required. Is BLS enough? Yes, BLS is enough for your CPR certification.
Another thing about the CPR, and I don't know if there is any provider level that is just truly online. The rule now says your CPR must include a live component to
Yes.
it. So some of them, there are some internet programs where you can do some study online and then go to a place where you get the live, and then there's some that's just totally online. Going forward, a totally online CPR program will not be allowed. And I don't know if there are any provider level ones.
Someone asked about the changes to on refilling refill consolidations. 338-202 was amended to provide, currently you can consolidate refills up to a 90-day supply. That 90-day supply limit doesn't apply if the prescription is being dispensed to a member of the military who is serving outside of the United States, or if it was issued to a prescriber or by a prescriber that is not located in Missouri. However, the prescription has to comply with the laws of the prescriber's home state.
We have a 3PL question. When should we expect 3PL licensure to become effective? When will we start issuing those licenses?
We anticipate doing that in September right now. Again, the board needs to approve an emergency rule that is actually online right now as part of the August 15th agenda. So if you're interested, please go look at the board's website, look at meeting information, and you can see the draft rule. Once the draft rule is filed, if we do it as an emergency, we anticipate having the licensure program ready to go in September.
Okay, again, I think you answered this. Someone wants clarification on who needs the training for Show Me Vax if a chain is automatically doing the reporting for the chain.
Who needs the training to report to Show Me Vax?
Yes. It says, do pharmacists still need to be trained?
According to the Department of Health, only those individuals who are reporting to the system, so the users. So if the pharmacist is not actually reporting data, that they are not required to do the training. The training is really focused on how to report. So our understanding right now is that if a chain or if another pharmacy, if your tech is doing your data, will be doing your data entry for you, that individual is the person that needs to be trained. And if you want to get a start before August 28th, as we approach very rapidly flu season, if you want to get started, I understand that they can begin working on the online training now, even if the other pieces have not been figured out or not in place, meaning you're not currently registered to fully comply or report to the system. So if you'd like to, you can get a start on that now.
So we have someone asking about a video of this, a recording of this. We announce, once we get it and post it on our website, we add that to an email alert to tell everyone that it's available. If you want to look sooner, you go to our website, under publication and resources, you'll find a section of all our videos, and that's where it will be posted.
Got a few other questions. Can a pharmacy look up history on Show Me Vax? Yes. Once a pharmacist or a licensee is registered in Show Me Vax, you will be able to do a bit of historical information. So you will also, one of the things that Show Me Vax does is it will let you know if a patient is eligible for another vaccine or if there are other things you need to consider. The Department of Health is really pushing this out as a resource for licensees as well.
We have someone who wants clarification. Can pharmacists administer B12 shots when the patient is uncomfortable giving them to themselves? The answer is yes, but you have to follow the administration by medical prescription order rule. You'd have to have an NOI submitted for that. You'd have to follow all the requirements in that rule. And then you would have to get an order from the prescriber for that drug in order to do that. So again, yes, you can. It's different than the protocol and how you do it by protocol.
Someone's asked about the 7-day supply limit. Do you just trust the patient and ask them, is this a first-time prescription? What if the patient is pharmacy hopping? This will be a real problem because there may be some information you don't know. To a certain extent, you will have to ask and rely on the patient's statement. For some of you, you may be able to do some historical searches in your records. You may be able to call the prescriber and ask the prescriber some additional information, but there's a portion of this that we recognize you will be depending on the patient for information. But you should be looking for other signs. So if the patient is, if their address is in Louisiana and they're showing up in, in Missouri for a prescription, you may want to start asking some additional questions. Always look for the red flags as well.
We have someone asking that if you're in a hospital setting doing immunization, such as for employee health, are you still required to, you still need to have a protocol and enter into ShoMeVax? If you're a pharmacist, yes, you have to have a protocol in order to immunize, and the statute says any pharmacist that gives one must report to ShoMeVax. So yes, your hospital may be doing ShoMeVax reporting, but if not, then you would, as a pharmacist, need to make sure it's being done. Someone wanted clarification on when I said you can do new routes. They want to know, does that mean a different site, like in the leg, or is that a different route like IV? I'm talking like a different route, IV. The example would be like IV push or to start an infusion. Are the two that we have been approached with people wanting to do new routes.
Someone has asked if the board will suggest to the Board of Healing Arts that prescribers include indications on opioid prescriptions. I think that is something that the board has talked about, maybe sending some communication to Healing Arts. I think it will help with the rollout of the new statute, and that will take to the board meeting next week and ask the board about that.
Clarification that the consolidation of refills does not apply to controlled substances.
That is correct. It does not apply to controlled substances.
And then another another quantity question. If a prescriber writes for a greater than 90-day supply for a non-controlled drugs, can you dispense it all in a single fill? The answer is yes. There is no supply limit on non-controlled drugs. If it's written that way. What Kim was talking about is when you consolidate refills. It's written for 30 plus 11 refills, and you want to use some of those refills to increase the quantity up to 90, is what Kim is talking about on consolidation.
Someone's asked, does the annual review of administration vaccines by protocol still stand? Right now, if you're talking about the administration or the CE course, that CE course is still required to renew in NOI if you're immunizing by protocol. However, that is every 2 years. So we are going to check on compliance with that every 2 years as opposed to every year. Now, your protocol still expires every year. So you will have an annual requirement there. So your protocol will need to be re-signed once a year, but your actual vaccine program, your CE program, that can be taken within the 2-year renewal period. And I also note that the rule was expanded to not only include a class or a CE program on administering vaccines, but also on CDC guidelines. So it gives a little bit more flexibility.
We have a couple people asking about using a PDMP program to document the patient's history to determine if they've had 7 days. Yes, you can. We don't have any specific requirement to do that, but yes, that would be for those counties that are in the St. Louis program. Yes, that would be one tool you could use to determine. However, keep in mind that it's not a statewide PDMP program. That doesn't mean the patient didn't get something in a county that's not reporting. So I think you can use it to rule out they've had it before, but you may not be able to rule out if they've ever had any at all. So just keep that in mind using the PDMP. Someone wants to know, can you add refills to vaccines that need booster? If you're doing it by protocol, your protocol will dictate the booster or the subsequent follow-up in a series. If you're doing it by prescription order, then your order has to spell that out, what the schedule is, or if a booster is needed. If it doesn't, then you would need to contact the prescriber, and then yes, you could add it, or you could make a new prescription out of it to do that.
Someone's asked about suicide training and what suicide training qualifies for CE. The statutory change is not very specific right now. The board may be doing some rules on this in the future. There are some other changes in the CE rule that we probably need to do, but right now it doesn't specifically specifically say what type of program is acceptable. Prior approval, though, is required by the board.
Someone wants to clarify again, does protocol still need to be signed and reviewed by the physician annually?
The answer to that is yes.
Yes. There's
Yes.
no change to not needing a protocol. I
think a lot of these questions we may have answered in one form or another. Someone has asked about the difference between administering by medical prescription order and immunizing by protocol. I would point you out to the practice guide. Of course, very generally, administration by prescription order, you need an actual prescription to do that. Immunization by protocol, you are authorized to administer any vaccine that is authorized by 338.010. The lower age requirement, or the age requirement, only generally applied to immunization by protocol, subject to, of course, CDC guidelines and manufacturer recommendations.
And someone's asking for clarification on vaccines. With staying within CDC guidelines, their example is giving Gardasil to a 40-year-old. You cannot do anything by protocol outside of CDC recommendations. So you could not do it by protocol. However, you could do it by medical prescription order and getting a physician or a prescriber to order it for that person, then you can. And that also applies to the age limit, currently 12 going down to 7. By medical prescription order, you're not bound to CDC guidelines or any age limit for that. So there's always an alternative to use it, medical prescription order. I think we're going to have to end the call for today. Before we go, let's see. Other webinars coming up on September 20th. We're going to give a sterile compounding update. On September 27th, someone from the Missouri Institute of Mental Health will be coming to present on opioid prescribing. And then on October 3rd, I will be giving a review of all the changes to the Pharmacist Administration. That'll be after the new rule on protocols and effects, so I'll cover the 2 rules and the statute changes again for everyone. So those are our next webinars. Again, all our past webinars are on our website, and this year we had the BNDD webinar and we had a webinar for technicians. Those can all be found on our webinar. So in order to get CE, you must answer the survey at the end of this program. When the program is done and I tell you I'm going to close it, a window will pop up on your screen saying the organizer has ended the webinar, and then says exit to exit. And then you need to click OK to that. Do not close your browser, and then a survey will automatically pop up. If you do not get the survey, you can email us at compliance@pr.mo.gov, and we will email you the survey. If we do that, you must get your answers back within 24 hours in order to receive CE, and we will mail out the certificates in approximately 30 days. I guess we need to get them out sooner since renewal time is coming. So we'll make an effort to get them out sooner. So I am now going to close the webinar.
Thank you everyone for attending.